speaker is Dr. Andrea Zambrano, who will be talking about whether all patients with acute aspiration should be promptly treated with antibiotics.
Thank you, everybody. I'm one of the second-year residents, internal medicine residents. And this is a very important topic. It comes up every day in the ICU rounds. So we thought we could share it with you and some knowledge. So there's various types of aspiration and of external substances, but for the purpose of this talk, we're going to focus on the aspiration of inhaled or oropharyngeal or gastric contents, which is the most common things we see in the hospital, into the respiratory tract. So within this group, there are different types of aspiration. There's aspiration of gastric content alone, which is usually sterile content and usually has a pH of less than 2.5, so it causes the chemical injury. There's also gastric food particle aspiration, which is kind of what we saw in the clip, which is larger particles that usually cause larger airway obstruction. There's combined gastric food particle and also acid food aspiration. It's kind of the worst type of aspiration. And there's bland aspiration, which refers to enteral feeds or blood, especially with like hematemesis or epistaxis. It can also be symptomatic or asymptomatic and indolent. The risk factors, as we all know, for aspiration, the main one is anesthesia. That's why doctors like to keep patients NPO for at least 8 hours. And depressed mental status due to sedatives, seizure patients, dysphagia that we see all the time in like stroke patients, neurological conditions, esophageal dysmotility, bowel obstruction, and gastroparesis. And then there are risk factors for bacterial colonization and risk for pathogen aspiration. And that's when we increase the pH of the gastric contents by, for example, PPIs, poor oral hygiene patients or gingival problems, enteral feed or tube feed. So having tube feeds increases the risk of colonization of bacteria, bowel obstruction, and gastroparesis as well. So there are several pulmonary syndromes when people aspirate any of the previously mentioned contents, and they may occur right after aspiration, depending on the amount and the nature of the aspirated materials. The symptoms are different. The frequency of aspiration, whether it's a one-time event or if it's a recurrent chronic event, and also the host's immune response to the aspirated material. So as we said before, there could be airway obstruction, there could be formation of lung abscesses, chronic interstitial fibrosis, diffuse aspiration bronchiolitis, but we're going to focus mainly on acute aspiration, so acute pneumonitis or aspiration pneumonia. So it usually, the contents usually go to the lower bases, as we can see in the plain X-ray films. On the left side of the screen, you'll see a CT scan of that diffuse bronchiolitis, and you can see the bronchial thickening, and that's usually happens with elderly people in chronic aspiration. But then on the right side, we have pictures. Like I just, went to Radiopedia and I Googled and I looked for aspiration pneumonitis and then aspiration pneumonia, and they're pretty much look the same. So radiographically, oftentimes it's really hard to differentiate between both of them. What we know is that it goes to the dependent areas and usually lower lobes, but it can go anywhere. So definition of aspiration pneumonitis, it's an acute chemical lung injury, and it's caused by inhalation of gastric contents. It usually presents abruptly and can progress very quickly to respiratory failure and ARDS. It's followed by a rapid improvement within 48 hours after the initial insult. And supportive care is the mainstay of therapy. Roughly 25% of these patients will develop secondary bacterial pneumonia between 2 to 7 days following the aspiration. And this can be usually diagnosed by the worsening of respiratory status or simply by the patient not improving after the 48-hour period. So the last statement, the prophylactic antibiotic therapy at the time of witness or suspected aspiration event has not demonstrated to prevent development of pneumonia, and we'll see why in a minute. Aspiration pneumonia, on the other hand, is a lung infection related to aspiration of colonized or pharyngeal bacteria. And it's usually a gradual onset of symptoms. It does not present acutely. The lack of expected improvement, as I said, within the 48 hours after a suspected aspiration or a risk of aspiration patient, it's suggestive of pneumonia rather than pneumonitis. And then it warrants empirical therapy if we don't know what the pathogen is. And then the most common pathogens, based on like the most recent literature, they're usually strep pneumo, H. influenza, Staph aureus in regular healthy patients, Enterobacter, Pseudomonas, and other gram-negative, usually associated with patients that are in the hospital. And then the diphtheroids and anaerobes are only associated or mostly associated with patients that are chronic alcoholics or have like gingival issues or very, very poor oral hygiene. But it's no longer the most not the common pathogens that we see on a regular aspiration pneumonia patient. So anything that goes into the alveoli, whether it's a bacteria, the chemicals, or food, or whatever, it causes an injury. So on the right side of the screen, you can see what a normal alveolus look like, and there's some epithelial cells, the basement membrane, the interstitial space, and the capillaries. Everything looks great. There's the alveolar macrophage ready to eat anything that gets in there. Then when you have an insult, then all this gets disrupted. There's specifically with acid, there's the dissolution of the cells, there's edema of the membranes, of the interstitial space, there's increased capillary leak, and there's a lot of interleukins that are secreted with this inflammatory response. So as it would be expected, you can have a systemic inflammatory response similar to the one you would have when there's an infection. So both pneumonitis and pneumonia can present with fever, tachypnea, cough, respiratory distress, and also infiltrates on chest radiography. So both of them have radiographic evidence, which is important to know because that doesn't mean that it's pneumonia versus pneumonitis. So distinguishing between aspiration and pneumonia is not always clear. If there's the witness event, I mean, obviously that's easy, but if there's no a witness event, or if this is something that is just suspect, that is not always clear. And so patients with aspiration pneumonitis are often critically ill or in the hospital already, in the ICU. So withholding antibiotics in these patients for 48 hours can be challenging. And also there are special conditions in which colonization of the gastric contents are suspected, like diabetes with gastroparesis patients. So in those cases, treatment, early treatment is reasonable. So identifying aspiration and aspiration risk is very important in terms of like what to do. Should I give or not give antibiotics? Also, rapid improvement of the symptoms is helpful to kind of go towards the diagnosis of aspiration pneumonitis and withholding antibiotics. And it can also be a guide as to when to discontinue antibiotics, because if we're not sure that it was an aspiration or if this has been brewing in, it's a pneumonia, we start antibiotics, but the patients quickly improve after the aspiration, we can probably say, it can help us discontinue antibiotics sooner rather than later. There's also a lot of studies, well, not a lot, actually few studies, where they've tried to use biomarkers like procalcitonin, CRP, even bronchoalveolar lavage, pepsin measurements to differentiate between aspiration pneumonitis and pneumonia. And they're not very specific. They can be elevated in both both occasions. Obviously, patients that develop the pneumonia might have aspirated before. So none of these are very helpful, and they're not very specific to differentiate both of them. So some of the historical aspects that we should know is that, and where do we base our data of like, should we give antibiotics or not? So the first study that was described in 1946, it was a doctor who studied aspiration in obstetric patients that underwent anesthesia. And he was the first one to describe the importance of acid in the pathogenesis of aspiration. He studied, or he described 44,000 patients from 1932 to 1945. He described different types of reaction. He described an obstructive reaction, an asthma-like reaction, cyanosis, tachycardia, dyspnea, and also fever in this type of patients. He also conducted, in the study, they mentioned some animal experiments with rabbits, and he described the lesions caused by the aspiration of gastric contents were very similar to those as caused by inhalation of hydrochloric acid. And they were also, he described how chest x-rays can be altered even in aspiration pneumonitis. There are infiltrates usually in the lower bases. There's also pathology that shows damage to the alveoli, just like you would with inflammation or any other cause of insult to the lungs. And then he was, in this paper, they mentioned the value of prophylactic penicillin and sulfonamides when these patients aspirate. So this is kind of the first time when it's mentioned, like, oh, any patient who aspirates, maybe we should give prophylactic antibiotics. The treatment was also focused on bronchospasm, and then majority of the patients recover. Even chest x-ray was clear within 7 days. In the 1970s, there was a lot of interest in bacteriology for aspiration pneumonia. So there were a lot of little studies trying to figure out what the more common bacteria was when people aspirated. And here's where we got the guidelines of we should cover anaerobes when people aspirate because of the mouth flora and this and that. So looking at most of them, most of the specimens and most of the patients studied were alcoholics. There were samples obtained on a later course of the disease, so most of them have abscesses, empyema already. So obviously we're going to find anaerobes in abscesses and empyema and necrotizing pneumonia. And then, as I said, most patients were alcoholics. There was description of putrid sputum even before they developed symptoms. So it's a kind of an old guideline. So moving forward, there's this paper from actually 1979. It talks about antimicrobial therapy in pulmonary aspiration. And they describe the different aspiration syndromes of non-toxic substances, toxic material, and oropharyngeal secretions. So they kind of differentiate between sterile and non-sterile material. They talk about the role of infection in the aspiration patient. And they say, okay, maybe they inhale sterile contents, but the chemical burn predisposes to superimposed infection, so it puts the patient at higher risk for developing an infection. They said, however, they describe not all of these patients develop infection, so there must be a reason for that. They also emphasize the time frame of aspiration and the pneumonitis. Those 48 hours are critical. And then patients with mechanical ventilation may be at higher risk because of difficulty clearing airways and pulmonary toiletry and so on. And then if the infection is present, they start talking about antibiotic choices, that covering anaerobes is not so important unless it's that specific group of patients that are alcoholics or with oral diseases. So in their conclusion here, they say infection has not been shown to play a role in the initial pulmonary complications following an aspiration, either inert or toxic. And then whoever elects to use prophylactic antibiotics in this setting must weigh improved benefits against potential risks of the antibiotics. So another study, this one is 2003. Sorry, I don't know, the date kind of shifted, but so this was a retrospective cohort study of 195 cases of aspiration from nursing home patients. And they divided the events on aspiration, definite or suspected, aspiration pneumonia, defined by symptoms and signs of lower respiratory tract infection, no aspiration history with a chest X-ray infiltrate, and then aspiration pneumonitis was signs of symptoms of lower respiratory infection with a history of aspiration, and again also a chest X-ray infiltrate. So 143 patients, that's 73%, receive antibiotics in the ED. Of those, 128 were continued on antibiotics once they got admitted, and only 13 did not receive antibiotics. So their conclusion was that there was no difference in mortality between the antibiotic and no antibiotic group. There was no difference in length of stay for those who received antibiotics very quickly versus the ones that were started antibiotics after being admitted. And the aspiration pneumonitis group were more likely to receive no antibiotics, and there was a trend of decreased length of stay. So not significant, but there was a trend observed. The main risk factors were having feeding tubes for these nursing home patients and dysphagia. Most patients recover between 24 and 36 hours. And then they reference in their literature other studies of aspiration pneumonia that may have included patients with aspiration only. And so saying, oh yeah, antibiotic improves the outcomes may not be so accurate for other studies that lumped all these patients together. So the main point was to differentiate patients who have had an aspiration event, so digging into the history, or even if it's a suspected aspiration, they're most likely to have pneumonitis and not pneumonia. So they have this diagram, the one on the right side of the screen, and this is kind of what they proposed to divide these patients up. So if they have a history of gastric content aspiration, yes, you do an X-ray, and they have an infiltrate. Maybe it's an aspiration pneumonia, but if the duration of symptoms is more than 24 hours, yes, then you can give antibiotics. But if it's not, then it would be reasonable to not give antibiotics and wait for the 24-hour, 48-hour period to see if it was just aspiration and the patient will improve on supportive therapy. If there was no history of aspiration with a chest X-ray infiltrate that was positive, then presumably this is pneumonia and has been developing over a course of time without aspiration event, and you give antibiotics. And if it's negative, no X-ray infiltrate, maybe it's bronchitis and maybe something else. And then on the other side of the screen, that's taken from another paper from the Critical Care Medicine Journal, where they also, this is for ICU patients that they're trying to see, well, if there's a witness suspected aspiration event with acute respiratory failure, so severe aspiration event, yes. Does the patient require intubation and mechanical ventilation? Yes. Then they recommend doing a bronchoscopy and getting good cultures, because 48 hours later, if the cultures are negative and the patient's improving, it's reasonable to stop antibiotics and not treat for a full 7-day course. Versus if the patient does not require intubation, more supportive measurements and observation may be more reasonable than just starting antibiotics. So this is another study. I thought it was very interesting. It's from 2014. It's aspiration-related deaths in 57 consecutive patients. This is a pathology study where they found that aspiration pneumonia, aspiration pneumonitis, and large airway obstruction as a cause of death for these patients. Obviously, the patients that had large airway obstruction, they died within 72 hours. They were most older patients, like above 70 years old. Aspiration events were identified in 22 cases of pneumonia and 19 cases of the pneumonitis. And of those, 74% and 27 died within 72 hours. And the point I want to make with this statement is that aspiration pneumonitis can be very severe, and patients can develop ARDS and can die from aspiration pneumonitis if the content of aspiration is large enough. But that doesn't mean that we have to right away give antibiotics. So most deaths occur in elderly patients with the risk factors we talked about. And then antibiotic administration was done in 88% of the cases of aspiration pneumonia and 92% of aspiration pneumonitis. So basically everybody got antibiotics. The micro results, so they took cultures, and the only 9 patients under the group of aspiration pneumonitis grew pathogens. I mean, this is not very specific because sometimes we don't isolate pathogens. But they didn't do a subgroup analysis to evaluate the benefits of antibiotic therapy or not. I just wanted to point that aspiration pneumonitis can be very severe, and pretty much everybody's getting antibiotics. So this one is a very good review of literature from 2013. It's an extensive literature review of the treatment of clinical aspiration. This is one of the reference for my statement about the biomarkers. They reference a lot of the papers that have studied procalcitonin, CRP, pepsin, and other markers that are very complicated to obtain, so I didn't mention them. They're not practical. And then they talk about the antibiotic practices over time. And so 97% of the patients with aspiration are getting antibiotics usually. And they did a survey on the critical care physicians and pulmonologists, and 78% of them answered that they would prescribe antibiotics in the acute event of an aspiration, even in the absence of an infectious process. So basically, prophylactic antibiotics. They concluded that the management of aspiration should largely focus on whether the underlying problem is pneumonitis versus pneumonia, because that would mean supportive treatment versus antibiotics. And then recent studies of aspiration pneumonia have begun to show a difference in culture-isolated bacteria. There's therefore optimal treatment regimens compared with pivotal human trials. So this was in reference to the statement that, we have to cover anaerobes in aspiration pneumonia. Well, that's not the case. That's only recommended for patients that, again, are alcoholics or have very bad, poor oral hygiene or gingivitis or anything. Otherwise, we have to cover for the most common pathogens that we talked about. Then there's this paper from 2017, Pneumonitis and Pneumonia After Aspiration, and they focus on mainly the incidence. So they say like 1 on 2,000 to 30,000 patients, a pretty wide range of anesthesia patients have aspiration. 3 of every 10,000 aspirate in the case of emergent surgeries where they don't have the proper fasting time. 18% of nursing home patients with nursing home acquired pneumonia are found to have aspiration. 5% of total community acquired pneumonia is approximately what is due to aspiration. And then this was interesting because they found that 88.9% of ICU patients have at least one episode of aspiration. So that's a lot. And they based this on measuring the pepsin in bronchoalveolar lavage. And almost 90% of patients at some point have aspirated based on the presence of pepsin in the BAL fluid. Most of them are silent aspirations, so it's really hard to determine when the insult occurred. The risk factors for bacterial colonization are mostly PPI, tube feeds, gastroparesis, SBO, and poor oral hygiene. And the risk factors and prevention are basically dietary interventions, so dysphagia diets, NPO, post pyloric tubes, superior to gastric tubes, they found in this study. And then bed positioning of more than 45 degrees, fasting pre-op. They also commented on the development of ARDS, which we already know, and how difficult the diagnosis can be if the aspiration is not obvious. So we have to have a very high suspicion index. Usefulness of BAL in intubated patients, not that useful. It's pretty unpractical. We don't do it routinely. And then they also concluded that antibiotic therapy is not necessary in aspiration pneumonitis. It would be reasonable to wait that 48-hour period that we've been talking about. And they also made some recommendations on antibiotic trends. And this is the latest studies from 2018. And it's prophylactic antimicrobial therapy for acute aspiration. It's a single-center retrospective cohort study from University of Toronto. They compare the outcomes of patients that had aspiration pneumonitis divided into 2 groups. So patients that received prophylactic antibiotics and patients that received only supportive therapy. The primary outcome was hospital mortality within 30 days. And then the secondary outcome was transfer to critical care, escalation of antibiotics, or antibiotic-free days measured between day 3 and 14. So they reviewed 1,483 cases. The inclusion criteria was a witness aspiration event plus X-ray infiltrate. Patients were not on antibiotics at the time of the aspiration. They were not intubated. 200 patients met this specific criteria. They calculated this comorbidity index, so they accounted for all the confounders and comorbidities. And in the graph, we can see that the unadjusted 30-day inpatient mortality was no different, but the difference is mainly in the antibiotic-free days and also the escalation of antibiotics. So usually if they're started on antibiotics, they're gonna continue the antibiotic therapy or even escalate to further antibiotics. So the limitations for the study is that it was small, not powered to detect a 10% or less than 10% difference in the mortality. Maybe that's why they didn't find any differences. And it was not designed to evaluate the impact of antibiotics in the development of pneumonia, so we don't have that data. But they concluded that prophylactic antibiotic therapy for patients with acute aspiration did not offer a significant benefit, and it would just mean that patients would get more antibiotic days, and they tended to have more escalation of antibiotics. They also referenced that study where it says like 78% of the MDs were prescribing antibiotics, even with the lack of supportive data. There's like no clinical trials at all on this subject. So it's pretty limited data, small reviews and things like that where we have. And also based on presumed risk after the lung injury. Our conclusion, or I guess my conclusion based on what we read, it's like there's no sufficient data to support prophylactic antibiotic therapy in acute aspiration and aspiration pneumonitis, even when it's severe, even when patients have intubation or develop ARDS, there's no data to say they improve because of antibiotics or not. Despite these, 78% of physicians of us are prescribing antibiotics in these scenarios. PPIs, poor oral hygiene, SPOs, and gastroparesis predisposed to oropharyngeal and gastric colonization of pathogens. The use of antibiotics after aspiration in patients with fever, leukocytosis, inflammation markers, and chest x-ray is discouraged. And then antibiotics are indicated in patients who fail to improve after 48 hours or patients that we already suspect the bacterial colonization. So there's specific cases for it. Limited data on corticosteroids also. There's a couple of small studies with 60 patients, 140 patients, and there wasn't really any benefit, but they did see increased rate of gram-negative pneumonias for patients who receive steroids, so that's also debatable. And the most important part is identifying risk factors and preventing aspiration. These are my references, and thank you. I hope I can.
Thanks for that great presentation. Before we get to the question, well, this is the question. Anybody have any comments?
The population of patients where there's a witnessed aspiration event and the population of patients who come into the ER in respiratory failure from an aspiration at some point in the last 48 hours are actually probably pretty different. And I think the threshold might vary for giving antibiotics for someone who sort of aspirates on the floor here versus someone who comes in ARDS on event in the ER, because you don't actually know whether or not they have pneumonia or not. So it can be really difficult to differentiate those groups.
Well, if they were fine, before, if they came and they tell you like, oh, this patient just had acute shortness of breath, decompensated in like the last 24 hours because they come in so sick, right? So and they have all the risk factors for aspiration, you can presume that, oh, this patient probably aspirated, required intubation. So that's the question. So are you willing to withhold antibiotics for 24 hours and see if he improves without them? But this is like...
Right,
yeah.
so that's what I'm saying, is that when you have a good story, when you have a convincing story for a recent aspiration event, it's not quite the same as like the alcoholic who's found down the street, who aspirated however long ago, an unwitnessed event.
And that was one of the points they made, that the person that has a witnessed aspiration event, you're probably more likely to want to watch rather than treat. But I think you had a...
Well, my only comment is I've tried to talk people out of treating aspiration with very little success. I think most of the time they're so dedicated to giving antibiotics from the very beginning, you can't even stop that. And then later on, if there's an infiltrate that shows up on an x-ray, the antibiotics are started even if the person is stable, and if there's a little bump in the temperature, they get antibiotics. So I think it's virtually impossible to stop it.
And I think for the patients you mentioned, Yuri, also, if you decide that they may have pneumonia and you start treating, if they improve significantly very quickly, it's unlikely that this was pneumonia. So that's what they tell you. You can use some clinical judgment in helping you out when to stop them and not complete a full course, maybe,
Dr. Wright.
one thing just want to reiterate, if you have aspiration and you think it's food, that is a definite indication for immediate bronchoscopy. If you think you've got retained food particles, I'm not saying for antibiotics, but that's something that we get called, and sometimes you can't even see in an x-ray, but the history is really that they aspirated food, and you think you've got residual particles down there, they should get bronchoscopy, not necessarily antibiotics.
Actually, in some of these papers, they basically make a point not only of that, but that patients who have gastric acid aspiration with food particles are at higher risk for pneumonia and should be treated. So I think that was in one of the.
Yeah.
And you know, in some of the original studies with gastric acid, they actually did immediate bronchoscopy, and they had two groups. One was they just gave saline to try to lavage out the gastric acid. These were in animals, made no difference. And of course, the other, they would put down bicarbonate solution, and that made them much worse.
Any other comments from anybody? Well, I have a comment because I saw this presentation last night for the first time, and I was actually a little disappointed that there isn't more data. There's really been clearly no randomized control trials looking at this, and there's really not been a lot of data. And even the data that you presented is really not that strong. There's a lot of recommendations not to treat, but there's not a lot of data to support that. So I was actually surprised. I thought there would be much more because there seems to be such a routine recommendation from a lot of quarters not to treat initially a lot of these patients. So that's just from my standpoint, and I think that it is extremely difficult when you have a patient in respiratory failure to not treat. It's such a difficult distinction to make between pneumonitis and pneumonia clinically. So do you want to take the chance? And I think that's why more than 3/4 of pulmonologists end up treating, or intensivists in the survey they did. So how many think that this statement is, or that this is a myth, that all patients with acute aspiration, I debated whether to say all or most, with acute aspiration should be promptly treated with antibiotics. Is it a myth? Okay, so that's probably a myth. Or at least most people think it's a myth. How many think that it's plausible that all patients should be treated with antibiotics? So there's several. And how many think that it's just flat out not true? Flat out true, I mean. I'm sorry. Sorry about that. How many think that it's flat out, that it's true? All patients with acute aspiration should be promptly treated with antibiotics. So nobody. So I guess the majority said that they would go with all. A smaller explosion because of the all versus most, because I just do think that it's a really difficult thing to do clinically to differentiate. Clearly, people with aspiration pneumonitis should not be treated with antibiotics. The question is, you don't always know.